during CGM use. Over to you, sir.
Okay, thank you very much for being here and also for inviting me. The first thing I want to say is I'm a clinician. I'm doing clinic. Okay, so although I'm going to talk about complications or limitations or cautions, it's because I'm visiting patients in the real life. Okay, but besides that, in the last 5 years, I've been advising what can I say, the Minister of Health directly, because I'm a member of an office that is working in innovation and research of all Catalan region, because as I said, I'm living in Barcelona, in Catalonia. I'm advising the Catalan government in terms of making decisions. So I have the two phases, very close to those ones making decisions and also visiting patients. Okay, so let me then move forward. I don't know if I can move. There's a clicker. This one? It's not working. Okay, so there's some technical problems. I think my colleagues are going to sort that thing. Let me do it like this. Okay. Okay, I think I have to talk about limitations and cautions, and my former colleagues already announced some of these things and probably already prevent aspects I'm going to share with you now. Probably one of the important things, and now I think these slides are just going to provide you some thoughts, some ideas. One of the critical things is the cost, and that has been explained in a very elegant manner by my colleague, showing that probably it's not the same, the opinion that is promoted by those medical societies, scientific societies based on evidence-based advice or papers, that ones that is coming from those ones have to make decisions and have to take into account other things, other domains in terms where have the money have to be spent. Okay, so for that reason, probably it's very clear that in type 1, that is no doubt, and that is cost effective, is reimbursable, etc. And in many countries, in Catalonia, for example, in Spain, is reimbursable for free for all citizens. Okay, but what's happening in type 2? In type 2 now, in my country, in Spain, is reimbursable for type 2 in intensive insulin regimes, but not for the other ones. Okay, so this is also under some criticism, and they are waiting for analyzing what's going on after 2 or 3 years of doing that and observing the data. But I think it's important to keep in mind that in different regions there are different reimbursement policies, and also if you can spend more money in health, then probably it's good to have this kind of technique, because of course it's providing you information, but this is sustainable, this is cost effective, and this is the point. And I think the lack of studies in type 2 is the reason that probably now is not fully reimbursed in those patients. Is of course sometimes, and I don't know here, but in my country it happens at the beginning that it was a break of stock. We don't have access. We have problems for supplies, and many citizens start using the device, and then in the middle of the process they don't have supplies, and that happens because sometimes the demand of these things are more than the capacity of producing the things. Now it's also happening with some compounds, and all of you probably are very aware about the GLP-1 receptor agonist things that are not available in many pharmacies in Europe because they have a lot of problems on supplies. In terms of insufficient health infrastructure, I think that this is a very critical point, this one and the next one. I think that when you want to introduce a technique like this, you also need to be fit, prepare. But prepare in infrastructure, it means that your electronic clinical record is going to have capacity to host this thing, okay, and probably to connect the data you have of that patient with the data you are providing with the CGM. And of course, also you need to have the clinicians to have access to that data. So you need to have interoperability, and this is a big issue. in terms of adopting, not just for CGM, for any technology. We have digitalization is a big area of innovation across the globe in terms to incorporate new adoption, incorporate technology into health, but we need to have more fit systems allowed to have to host these new things. Also, it's important to keep in mind that this is probably what is happening now. We have different databases for the same patient. Sometimes it's happening in one hospital. We have different databases. We all different softwares. Sometimes they are having difficulties to dialogue between that databases. It's also a difficult communication between the patient and the citizen and the system, and that is important to keep in mind because many of these the systems are reporting the data on a cloud. They can download it, but then the patient need to provide permission to the clinician to be downloading that results, consulting that results, and that have legal implications. And I think it's sometimes very important to keep in mind that also patients and patients associations need to be incorporated in that process of decision. Of course, what's happening in terms of research? I think it's very important if we are having this big amount of information, how we are using that information to generate new evidence, to understand what is the good value or the potential value of that data to generate new hypotheses. We know we have a perfect example with retinography. Okay, you know now if you are doing retinography to you of any of your patients, you can estimate the risk of heart attack, the risk of a stroke, because there are artificial intelligence combined with the photography of the retina, and it is producing algorithms that generate hypotheses and generate risk for that patients. So that is very important in terms to that if we have all of this data combined with other parameters of the patient, that could generate a lot of information that could bring a lot of value to profiling citizens and risks. And I think here is another point. CGM is not the solution. CGM is a tool that we need to understand and we need to use properly. And sometimes we think, and this is a self-criticism, that the solution is the CGM. No, we need to be part of that journey. I mean, we as a healthcare professionals and also help the patients to coach them in terms to understand and to squeeze as much value from this tool. And I think we have a perfect example of something I said, in my opinion, is a catastrophe. We spend millions of euros in my country in using CGM, SMBG, self-monitoring blood glucose, finger determination in type 2. How many of these patients are monitoring themselves? How many are up titrating or down titrating insulin? Less than 5%. So something is wrong. So it's not just the SMBG, the solution. It's not the CGM. We need to do something else. So that is very important. For that reason, I think we now in front of a good opportunity. We have an amazing tool. This CGM, and I had the opportunity to be in IDC, in International Diabetes Center in Minnesota in 2010, when they start working with that things. And for me, it was very inspiring that they start considering this kind of profiling, and I was in that period in that center, and how useful use that tool for type 1 and type 2 potentially. So I think that, of course, it's important that we have to provide good quality education together with that tool. And as has been said before, when you download the report, that is a very important tool in communication to support you when you would like to coach the person and help the patient to understand what must be the goals. And this is critical. And what is going now is sometimes patients come to our clinic just as seeing you just share how are you feeling, everything is okay, blah blah blah, but you are not squeezing value things from that encounter. And I think the idea of trying to use that encounter to revisit what's going on the CGM parameters is a good opportunity to reach a better commitment, a better better connection between you and the patient and their families, and also better commitment from the patient perspective. Also, it's important to understand that sometimes there are some limitations in terms of technical problems, okay? In terms of the sensor, connectivity, okay? Also, and now I think it's must solve. I've been using for a trial a Dexcom CGM. You need to calibrate that one every 12 hours. And then if you don't calibrate properly, analysis I think is bothering the patient. You have to be calibrating that one. Now all of these things has been more solved and I think are improved. Also sometimes between what you're observing on the system and what is the real determination is a delay. But then, of course, you have to train, you have to help the patient to understand that what they are observing on the device compared with the real parameter at that time have a gap. But this is a question of education, again. Of course, when you have extreme values, you have to coach the person and to help them to, okay, you have to recheck, you have to reassess because maybe something is happening and it's a wrong lecture. I think also is patient education is, in my perspective, a most critical thing. When I'm visiting patients in my clinic, because the patients came to my office just referred for my colleagues in primary care, my first question to them are, why are you here? What's the reason to come to my clinic? I say, I don't know. My doctor refers to you. So that's horrible because they don't know why they are coming to my clinic. And I think this is the first step to keep them like in this process. We need to, and this is CGM is a perfect opportunity to, with this amazing tool, to make the patients more committed and also to try to make them self-sufficient in the management of their disease. So this is my last slide, and I would like to keep that as a take-home messages. I think that CGM is a perfect opportunity to empower education that works, education of quality, okay? Education for healthcare professionals that need to understand what is CGM. Because sometimes, and that happens, a perfect example is type 1 diabetic persons living with diabetes, is patients living with type 1 no more than a general GP. Okay, because they are very familiar with that problem. So we need to be, as a healthcare professionals, primary care, internal medicine, whatever that is responsible to manage type 2 or type 1 and have to be dealing with CGM, please, yourself need to be more knowledge in terms to understand parameters, in terms to understand CGM. And I think the former presentation, it has been a perfect example of simplicity. Keep 3 messages, 1, 2, 3. That is very important. And just I would like to keep remaining on that thing. Of course, for the government's perspective, if you are is try to overcome the barriers of interoperability. That is very important. Also try to, what can we squeeze more from CGM? And I think all of these millions of data there can be combined with other data of the patients to generate new hypotheses, new information that could help all of us to understand better how this disease is moving on, and also how the CGM is also helping us together with other biomarkers to understand better this patient's profiling. Also, we think to need to elevate CGM as a high value based care profiling. Now in Europe is a new wave, a new fashion to be moving forward into high value based care approaches. That it means we have to start undoing things, stopping doing things that probably by inertia we are doing for years, but they are not providing value at all because our time is limited in clinic. So we have to be highly focused on high value care actions. And probably we have to consider how CGM could be a high value care intervention and action for our patients. And I think also we have to think in new models of reimbursement. Probably if we provide CGM for everybody, probably it's not sustainable, but probably if you have better systems that allow to understand who could be the best candidates, I think in type 2, that could be better responders to this kind of technology, probably we niche better who will be a good candidate to be under that system and that technology. So that are my final messages, and thank you very much for keeping here.